I'd like to call to the stage Dr. David Ilson from the Memorial Sloan Kettering Cancer Center, who's going to talk to us about genomic testing. And at the same time, I'd like to call Dr. Antonio Ucar to the stage as well.
Down here.
Okay, well, thanks, Libby. It's a pleasure to be back speaking at this symposium, and certainly a privilege to have worked with Debbie Zellman over the last 6 to 7 years in supporting her foundation and all the incredible accomplishments that she achieved during that time. So I'm going to talk about the era of genomics. I think Dr. Catenacci touched on many of the issues already. And I'll try and highlight some of the practical implications of this and how it can impact on patients and their care. So esophageal and gastric cancer, they're not actually that uncommon if you look at them together. About 44,000 Americans a year will develop this cancer, about 3% of all cancers. Gastric cancer is still more common than esophagus cancer, but it is decreasing in incidence in the United States. And we're seeing more tumors in the part of the stomach that's near the esophagus and the junction between the esophagus and the stomach. And although we have seen survival improvements over the last several decades, you can see at 5 years that there's still a lot of improvement to be made with 5-year survivals for these diseases only ranging about 20 to 27%. And this is a huge unmet need and an area that we need to devote research resources to try and improve outcomes. So if we look at how this disease stacks up and compared to the rest of the world, if we look at the top, you can see very high incidence rates globally of gastric cancer in Eastern Asia, in Eastern Europe, and South America. And if you look way down at the bottom, you can see North America, where this is a relatively uncommon disease. So a lot of the drivers of research and advances are going to come with our collaborations with our colleagues in East Asia, where this is a very, very common disease, and sometimes clinical trials and drug development can be done more quickly. So to treat stage 4 disease, Dr. Catenacci talked about this a little bit. The mainstay of treatment is chemotherapy. We now know, and there was a question from the audience about how, should we give chemotherapy over a day or two? Should we give it over 5 days? It's pretty clear that we need to apply lessons learned in colon cancer, where treatments like Folfox, Folfiri, Xelox, capecitabine, oxaliplatin, these treatments have a lot less side effects than the way we used to give chemotherapy 20 years ago, and we really model our treatment of patients on colon cancer-based regimens. What about 3 chemotherapy drugs? This really escalates the side effects. Epirubicin added to platinum 5-FU, that's really kind of been put by the wayside. It's not clear whether epirubicin adds benefit. Adding docetaxel or Taxotere to platinum 5-FU and the DCF or FLOT regimen. These treatments give you a little bit of benefit, a little bit of survival improvement, but much, much greater side effects for patients. And epirubicin really has been dropped from NCCN guidelines, and we really don't use it anymore. And really the 2-drug chemotherapies are going to be the best option for patients to get treatment. So what about secondary chemotherapy? We now have ramucirumab, which improves outcome in second-line chemotherapy. We usually use Folfox first line, and then we use weekly Taxol as a second-line treatment. And this was a very important study in second line. It was a global trial which looked at Taxol alone or Taxol plus the drug ramucirumab. Ramucirumab starves the blood supply to the cancer. And this showed a modest but significant improvement in survival for patients with a reduction in the risk of death of about 20%. So now we have standard first and second line chemotherapies, but obviously these treatments don't help everybody, and many patients run into problems with the cancer after the first year to year and a half. So because conventional chemotherapy has rather modest benefit, we are now looking at targeted agents, which are attempting to block, more specifically, tumor growth pathways. So Dr. Catenacci talked about how chemotherapy affects sort of gross DNA synthesis and other cell division properties in the tumor cells, but it's not highly specific, and it has side effects with normal tissues. So our hope is that looking at targeted agents, we're really going to try and hit the cancer cell in pathways that drive the cancer cell to grow and divide more quickly and try and more spare side effects from normal tissues. So the targeted agent categories include monoclonal antibodies. So these are drugs like trastuzumab and ramucirumab, and also immunotherapy drugs like pembrolizumab and nivolumab. Tyrosine kinase inhibitors, this is sort of the business end of the target. The monoclonal antibodies sort of bind on the cell surface and block the growth pathways, but the business end of the molecule is really the tyrosine kinase that transmits the signal into the cell. Results with tyrosine kinase inhibitors have largely been disappointing. And then we also have to look what happens later in the cell, how we can impact on these growth pathways later. So how does this tie in with genomic studies? Well, in the genomic studies, we're looking at the mutations and the abnormalities and the gene amplifications in the cancer, as Dr. Catenacci discussed, to really identify what are the targets that we can look at in cancer cells for new or existing drugs. So how do we do genomic profiling? For many years, we were pretty primitive in how we did this. We had our pathologists just look at the tissue, and they would stain the tissue for, what proteins were present, because obviously these targets are expressed proteins in the tissue, and you can stain for them by doing immunohistochemical stains. The pathologist can do this, and this is what we still do even in 2018. It's not like we have to rush and do genomic testing on everybody. The pathologist can take a biopsy and do stains in the laboratory. And in 2018, aside from just making a diagnosis of cancer, in 2018, this is important, that all patients with gastric cancer need to have testing for HER2, for PD-L1 expression, because we have approved drugs that treat these pathways. Another approach to quantify the target in cancer cells is FISH testing. This measures the copy number of the gene. And this is done less frequently in gastric cancer. It's done more commonly in breast cancer. And then now we have the era of whole exome sequencing, where we look at the entire genome of the cancer, again, looking for mutations in the genes and amplification of genes that might be targets for drugs. So an important advance came in the U.S. with publication of the Genome Atlas data. Adam Bass's group at Dana-Farber spearheaded this NCI initiative, where they took nearly 300 fresh frozen biopsies from stomach cancers, and they looked at several different platforms to characterize the genomics. And the one I'm going to focus on is the whole exome sequencing. So that's where they look at a battery of hundreds of genes, looking for activating mutations and amplified genes that might give us an idea of not only about the biology of the cancer, but are these pathways that we can potentially exploit for drug development that we may be able to inhibit cancer growth. So this was one of the early publications from the Genome Atlas group, again, 300 fresh frozen biopsies. And they actually showed that gastric and esophagus cancer are largely driven by gene amplification. So there are some cancers where you have an activating mutation, and that mutation drives the cancer. In esophagogastric cancer, it turns out that amplification of the genes, you have more copies of this gene present, and the enhanced copy number of these genes enhances the expression of that driver of the cancer. So it turns out in this study that 47% of the tumors had some gene that was amplified, and a number of them are important and can potentially be targeted by drugs. And those include the EGFR pathway, epidermal growth factor pathway, the MET pathway, the FGF receptor pathway, and HER2, which is probably the most important. Now, the RAS pathway, although it's not directly targeted, that RAS pathway sits downstream from all of these pathways. So So if we inhibit these pathways upstream, this might impact on the RAS driving of the cancer downstream. But as more often than not, we have lots of hopes that new drugs are going to improve outcome when we identify a gene that we're going to target with a drug, but you can see that many of the clinical trials of drugs that looked at trying to inhibit these pathways weren't successful. Several large trials treating almost 2,000 patients with EGFR-targeted drugs really failed to improve outcome compared to chemotherapy alone. Actually, some of the trials, when you gave the EGFR drug, the patient did worse. So just because something is new doesn't mean it's better, and you need to prove that if you're going to add a new drug to conventional treatment, you need to show it's safe and that it's better, because sometimes you think it's better and actually it turns out it's harmful to patients. And you can see that the real success story here only is the HER2 pathway, but as was commented on in the panel, unfortunately, HER2-positive stomach cancer is not breast cancer. Like the drugs that we have available to treat breast cancer, more often than not, do not have a benefit in stomach cancer. So what came out of the Genome Atlas is that stomach cancer is not one disease. 4 distinct subtypes of stomach cancer emerged from this analysis, and about 50% of patients have what's called a genomically unstable tumor. These are the HER2-positive tumors, the EGFR-positive tumors. They also have a frequent presence of a mutation called P53. So about 50% of stomach cancers can be genomically classified in this group. Then there's a group with a high rate of microsatellite instability. This is I wish we saw 22% of patients that had this in the U.S., but it turns out probably it's only about 10%. There were some Asian cases, stomach cancer, in this analysis. And in metastatic disease, only about 7% of metastatic gastric cancers are MSI high. But this is the subgroup that will benefit from immunotherapy. Then we have a subgroup called genomically stable tumors. There aren't a lot of mutations or abnormalities in this group. This often corresponds to the diffuse subtype of gastric cancer. And then a small percentage of stomach cancers have an association with Epstein-Barr virus infection. This is the infection that causes mononucleosis. It's also associated with a number of other cancers, and it's present in about 9% of stomach cancers. And this may also be a subtype of patients that may benefit from immunotherapy drugs. So why should my cancer have genomic profiling? Well, I think the 2 main issues are to identify this microsatellite instability. As Dr. Catenacci said, microsatellite unstable tumors have about a 60% response to pembrolizumab, and the drug is approved for patients that have MSI high tumors. So this is something that you need to test for. And MSI high patients, pembrolizumab again is approved after chemotherapy does not work. The other way to test for this, the pathologist can also test for this doing mismatch repair protein testing. So another reason to do genomic profiling is to make sure that we identify pathways like HER2. We have an approved drug, Herceptin or trastuzumab, which improves outcome in patients with HER2-positive disease. And then I think less recognized is this Epstein-Barr virus-associated stomach cancer. These patients also may potentially have a greater benefit for drugs like pembrolizumab and nivolumab. But the main reason, you could still argue that genomic testing is a research tool. There are important things that we need to learn about the cancer, but the most important is, because we have really limited approved drugs, is to really screen the cancer. Is there something in the cancer that we have a trial for, that we have a new drug? When patients have gone through all the conventional treatments and they're not working anymore, genomic profiling provides a potential rational way to direct a patient to a study where they have a mutation or an abnormality. So genomic profiling, again, looks for an amplification of a gene that could be targeted by a new drug, presence of a mutation or a gene fusion or rearrangement which the new drug targets. Now, sometimes these mutations and abnormalities are really uncommon. Like we might find it in like 1 in 1,000 patients. But I'll give you an example of TRK gene. Our group from Memorial recently published a paper in the New England Journal of Medicine where if you have a rearrangement of the TRK gene, you have dramatic responses to this TRK-directed drug. So it's kind of like winning the lottery if you have this in 1 in thousands of cases. But if you have this abnormality, you actually would get access to a life-saving drug. So I think there are clear rationales to do genomic profiling, and it's increasingly becoming part of standard practice. The FDA has now certified a number of these tests that are reimbursable by insurance. And I think we now are in the era where we really are doing this routinely now in our patients with metastatic disease, and these are the reasons to do it. So I think you should ask your oncologist about this. Certainly if some of this information has already been identified, if we know that your MSI low or that you're HER2 negative or your DNA mismatch repair proteins are intact, those are the important ones. But again, for screening for a research study or that rare patient that has a highly sensitive mutation, genomic profiling should be considered. So we talked about this earlier. We know that the EGFR gene is amplified in about 10 to 15% of esophagogastric cancers, but largely the drugs are negative. Panitumumab actually worsened outcome. Patients got panitumumab in this British trial had significantly inferior survival and more side effects. And the other European trial looked at cetuximab. Even that study, the patients trended to do worse when they got the new drug. There was a trial of a drug called gefitinib in the UK, which also was a negative trial. They reported that EGFR amplification or copy number might predict patients that benefit, but even in the patients that had that biomarker, the benefit was measured in weeks. So it's not clear whether that's a clear biomarker. So what are the other disappointments? MET receptor drugs, unfortunately, also did not improve outcome in patients that were tested by immunohistochemistry overexpression. So we had a number of phase 3 trials adding these drugs to chemotherapy that didn't improve survival. I think this remains a pathway of interest if we can find the right patients to treat with the right drugs. I'll mention the FGF pathway. There are some promising developments in this pathway. There are antibodies targeting this pathway, and these are data from a phase 1 trial where they actually used genomic testing to identify the patients that had either the amplification or the gene rearrangement. So here they selected out the patients that had the gene that was affected, and then they put those patients specifically on the study. So they didn't just treat everybody. They tried to enrich the population that maybe these are the patients that are going to benefit. And when you see a curve like this, we call this a spider plot. On the x-axis, that's the duration of time patients are on treatment. You can see some of these patients that got this drug were on it for a while and had quite long remissions. So I show this slide to make an argument for genomic profiling of your cancer to identify you as a candidate for a drug in a new study that might have benefits. Because right now, often we do clinical trials without markers. We're treating everybody the same way, and we know that stomach cancers are different in every patient. HER2 is the success story. The TOGA trial did show a modest survival benefit. If you see that curve on the red, showing a survival improvement in HER2-positive patients getting Herceptin or trastuzumab combined with chemotherapy. But as was talked about earlier, many of the other drugs that we use in breast cancer just did not work in stomach cancer. Trastuzumab worked, but there's an oral drug called lapatinib. That didn't improve outcome added to chemotherapy. And even pertuzumab, which is really promising in breast cancer, combining pertuzumab with trastuzumab also did not improve outcome as dual-targeted HER2 therapy. And we had a lot of hopes for a drug called TDM1, trastuzumab emtansine. That was supposed to be better than Herceptin, and that drug turned out to be no better than Taxol. So many of these drugs that work well in breast cancer really did not translate into a benefit in stomach cancer. And we're trying to understand why that's the case. If we look at biopsies of patients that progress on Herceptin, here's data from Sloan. I'm not blowing our own horn here, but these are interesting data from Sloan Kettering. where we actually biopsied patients after the tumor grew on Herceptin. And if you look at that third paragraph there, about 24% of patients actually lost their HER2 expression. So one of the reasons you may become resistant to Herceptin is that you get exposed to this drug, and then the cancer cells that lose the susceptibility actually lose the expression of HER2, and that's why they develop resistance. Then just a last comment on immunotherapy. I know Dr. Catenacci talked about this. Basically, what immunotherapy drugs do is they take the foot off the brake. For many years, I mean, in my early career as an oncologist, we always thought that all you had to do was stimulate the immune system to fight cancer. You give patients vaccines and stimulate, and decades of studies failed. And we finally realized what the cancer does is it puts a brake on your immune system. So what we need to do is give drugs that take the foot off the brake and allow your immune response to fight back against the cancer. And the two pathways that drugs have been developed for include a pathway called CTLA-4. CTLA-4 is involved in the antigen presentation of the immune system. And then PD-1, what PD-1 does is essentially it kills off your T cells. You activate PD-1 and it kills off the T cells. If you block that pathway, then the T cells can flourish and develop an immune response. So there are two positive trials. I know Dr. Catenacci talked about this, so I'm not going to spend a lot of time. Keynote 59 actually led to approval of pembrolizumab or Keytruda in the United States in refractory gastric cancer, and the attraction study of nivolumab or Opdivo in Japan also led to approval in Asia, and the data are now up for review in the U.S. for potential approval of nivolumab in stomach cancer in the U.S. Keynote 59 was a large phase 2 trial, 260 patients treated, and overall about 12% of patients had a response to pembrolizumab, but as Dr. Catenacci showed, the PD-L1 positive patients were more likely to respond and are also more likely to have a more durable response. So based on these data, the pembrolizumab was approved for PD-L1 positive stomach cancer. And again, as I said earlier, aside from testing for HER2, all patients with stomach cancer need to have their cancer tested for PD-L1 expression as well as MSI or mismatch repair protein expression. And that's if you're on active treatment. If you've had curative therapy already, you don't need to have this testing done. And what was also remarkable, what a swimmer's plot shows is those arrows indicate that the responses are still ongoing. So you can see that patients are still responding to this drug more than a year into treatment. And this is the MSI high patients. So just to show you how rare this is, they studied 174 patients in this trial, and only 7 patients tested MSI high. But those 7 patients had a 60% remission rate. So you need to know what your MSI status is, what your mismatch repair protein status is. And then we have the nivolumab trial, just to cut to the chase. This study did not really show a distinction between PD-L1 positive and negative. There was a survival benefit for nivolumab over supportive care alone. So I think, Jen, just the take-home messages from genomic profiling. Chemotherapy is still the cornerstone frontline treatment for metastatic stomach cancer, but it has modest benefits. 2 drug chemotherapies are the best treatment for most patients, FOLFOX and FOLFIRI, and we have a standard treatment when that stops working with paclitaxel plus Cyramza or ramucirumab. All patients with metastatic stomach cancer should have tissue staining for HER2 expression and PD-L1 expression, as well as MSI testing, and then the genomic testing to look for new drug targets and potentially identifying a clinical trial that may help the patient. Thanks very much.
Thank you, Dr. Ilson. So with us as well as a discussant, we have Antonio Ucar who's a medical oncologist. Thank you for being here today from Baptist Health Miami Cancer Institute. So will be a discussion today. So as you can hear today, there seemed to be a lot of negative trials, right? So But we have some trials on the horizon, I'm sure. So I want to open it up to Dr. Ukar, just opening up for the situation as like what treatments that do you see in the future that, that show some promise that are in clinical trials right now?
I think that the main promise that I see is actually the combination of chemotherapy with immunotherapy that has been talked about. And we have promising results from other malignancies, like lung cancer in particular. So I think that would be the next step, along with the development of new targeted drugs.
The same question?
Yeah, I think now we're really waiting for the results of frontline use of immunotherapy. There are trials looking at immunotherapy combinations versus chemotherapy versus a combination of chemotherapy and immunotherapy. So is it better to use these drugs up front early on, or should we wait till conventional treatments have stopped working? So there are two really pivotal trials that we're waiting results for. One is looking at nivolumab in combination with ipilimumab, so combination immunotherapy versus chemo alone with FOLFOX versus a combination of nivolumab and FOLFOX. So that's a pivotal study that's actually going to complete accrual in the next few months. Then there's an important trial of pembrolizumab, which is actually looking at pembrolizumab alone as initial treatment in PD-L1 positive patients versus chemotherapy alone versus a combination of pembrolizumab and chemotherapy. So those are really going to define whether we should move immunotherapy up to earlier lines. And then we are awaiting results of some combination trials of immunotherapy. I think we kind of hit a plateau with immunotherapy. We see which patients benefit. It's a modest benefit. And now we need to look at adding other strategies or treatments to immunotherapy drugs to improve outcome. There also now are studies combining immunotherapy drugs with preoperative chemotherapy and surgery. That's an important initiative, combining immunotherapy drugs with chemotherapy and radiation in esophagus and GE junction cancers. So there's a lot of focus on immunotherapy and, of course, using the genomic data to identify new targets for new drugs. The other thing, I'm not going to take too much time, but the other thing I want to make a point of is it's not likely that we're going to hit a home run just with one drug and one target. We probably need to figure out how all these pathways interact, and it's probably going to be combinations of multiple new drugs that hit different aspects of the same pathway.
Mm-hmm. Yeah. Any questions from the audience? Yes, please. Pat? Please use the mic so people can hear.
What are the general thoughts as to why stomach cancer is more prevalent in Japan and the Eastern countries?
Well, I mean, one of the reasons we think it's gone away in the West is because this Helicobacter bacteria was very prevalent. Because we didn't have good food preservation. We salted and smoked foods. We used nitrates. And one of the reasons we think stomach cancer, I mean, if you look 100 years ago, stomach cancer was one of the most common cancers in the United States. Stomach cancer and cervical cancer were big killers in the United States. And they've both dramatically decreased in the West. So that's one explanation. We don't really know. I mean, Japan is not a third world country. Why do we see so much stomach cancer in Japan? Mm-hmm. It's not, I don't know if we really have a good answer for that. But even in Japan, there has been a downtrend, but it's still in these highly developed Asian countries like Korea and Japan, stomach cancer is still very prevalent.
Well, one other question. In regard to the genomic profiling, you were suggesting that after conventional treatment, it's good to do the genomic profiling. Wouldn't it make sense to do it, earlier? And would that affect what treatment was rendered, and how much does genomic profiling cost?
It's gotten cheaper. It's gone from a few $1,000s to maybe $1,000 or even less in some places. Insurance often does cover it, but you have to worry about co-pays for this. We are encouraging to do it earlier if we have a clinical trial for a patient. And certainly, the MSI testing for immunotherapy, it really is going to impact later PD-L1 testing is really going to impact later. We are encouraging to do it earlier on, but sometimes we get information that we just can't act on. The actionable things would be HER2 testing and MSI and PD-L1. Pretty much beyond that, it's identifying patients for clinical trials, and we always don't have upfront first-line clinical trials looking at new targets. But we also don't want to wait too long when the patient's too ill to consider a study or not well enough to get some of these newer therapies. But oftentimes the initial genomic profiling is not going to impact on your initial choice of treatment with the exception of HER2 testing.
But I think one of the things that you could consider is the use of liquid biopsies if you're concerned about the evolution, the genomic evolution of the tumor. We talked a little bit about the loss of HER2 new expression. So that's one of the things that could be explored to see if there are new mutations that are developing throughout the course of the disease. And so instead of getting a biopsy, which would be an invasive procedure, just proceed with liquid biopsy instead.
I have a question. Some people are advocating for testing for Epstein-Barr virus. But there is a considerable overlap in that a lot of those tumors are going to be PD-L1 positive anyway. I think there are a few of them that are not, some 3% or something like that are not. Any thoughts about testing for EBV sort of in the same vein as we're testing for HER2 and those types of things?
Yeah, some of the testing panels now do it routinely. In fact, in our IMPACT, our in-house Memorial Genomic panel, we look for EBV. We're just starting to get trickling out of cases, but we recently reported a series from our genomic analysis where many of the EBV positive patients had really durable responses to pembrolizumab. So I think many of these, I think even Foundation Medicine is doing it now too. I think they're still not yet. But our impact analysis, we're looking at EBV biomarkers, and I think it's these also are patients that may have a better prognosis, certainly when they undergo surgery.
Question?
Right. Yeah, you showed some data about MSI high tumor that immunotherapy is quite effective for it, but yet it's only approved for second-line treatment. And there's some data that MSI tumor is not effective with chemotherapy in first line. You being a prominent member of the NCCN, can that be changed?
Well, no, I mean, you can't change NCCN guidelines based on 7 patients. I mean, that's not responsible. So, and you're never going to be able to do a study in 5% of patients. I mean, a very small percentage of patients. It may be that, I mean, we recently looked from our genomic database at MSI high patients seem to have more aggressive tumors when they had stage 4 disease. So they may actually have less benefit from upfront chemotherapy. There may be an argument in the MSI high patients not to wait till 3rd or 4th line treatment, but to try upfront conventional treatment briefly. And if they have no benefit from conventional treatments like FOLFOX, then the immunotherapy drugs might be better used earlier. But I don't think we can change NCCN guidelines to recommend that we give immunotherapy drugs as first-line treatment. Even in MSI high colon cancer, not everybody responds to initial use or even to these agents. I mean, the response rates range between 30% to 60%. So it's not that everybody benefits from these drugs, but it clearly needs to be part of the armamentarium, and probably it will move to earlier lines of treatment. But I don't think to put in your guidelines you should give it front line with no data is not a responsible action, I think.
Dr. Ukar, I'd like to ask you a question from online. What is linitis plastica, and are there specialized treatments for that? Linitis plastica?
So that's a diffuse infiltration of the wall of the stomach, a segment of the wall of the stomach or the entire stomach, and it's a relatively rare occurrence, about 5% of the cases. And it's an indication that the disease is advanced, basically. For these cases, we recommend actually a laparoscopic evaluation prior to the start of the treatment, and then if there's no evidence of metastatic disease, proceed with chemotherapy. and then evaluate for surgery. These patients often need total gastrectomy, and probably more treatment after the completion of the surgery with chemotherapy or chemo and radiation as indicated.
We have a question in the back.
Yeah, Patty Ray. I am an oncology nurse, and I also work for Lilly. And from the presentations, it seems clear that there is a standard for first-line chemo, standard for second-line chemotherapy. And of course, the very first thing you want to do is get a patient in a clinical trial. This is a very high unmet need. Also see that typically there's only 5% of places that, or 5% of patients go on to clinical trials. Of course, we want to increase that as much as we can. Given that, why do you think it is if we have a standard for second line, why are only 30% of people actually giving that drug?
Yeah,
I'm just curious. Like,
I don't know if I can really answer that question. I mean, at academic centers, this is the standard of care. I can tell you in Japan, where gastric cancer is a huge problem, the second-line standard with ramucirumab is widely applied. So I don't think
right.
I don't
Yes,
think
Japan is
that's
very
a question
different.
I can't answer.
Yeah. Okay.
It doesn't have an answer. I'm sorry.
Right. Okay. And then what should we do to educate, or just wanting to know what to do to help these patients? Thank you.
Thank you.
Any other questions, please?
You've implicated the Epstein-Barr virus in the causation of stomach cancer. How is that implicated? Does one have to demonstrate the Epstein-Barr virus immediately, or is there a history of mononucleosis, and how far back can you go? What are the criteria for implicating that?
Well, I think virtually everybody in this room has been exposed to Epstein-Barr virus, so it kind of insinuates itself in your normal tissue, and we think that it's some inflammatory process that results, but it's still a relatively small percentage of stomach cancers. It's less than 10%, and you can't get rid of it. I mean, you can't eradicate it. So I think it's not something we really can screen for, and EBV exposure is pretty ubiquitous. So, and we don't have a vaccine for it that I'm aware.
So we can go back into a patient's history and ask if they've ever had mononucleosis. It doesn't matter how far back.
Yeah, but it doesn't mean. Yeah, I mean, once you've been exposed to it, it's part of you, and you can't. It's like getting shingles, right, from chickenpox, right? It's in your body for a lifetime.
So how do you come to the figure or the percentage of anywhere from 5 to 10%? What does that mean?
Well, it just means that small percentage, that this may be a risk factor for those patients, but obviously the vast majority of patients, that get exposed to Epstein-Barr virus never have any cancers or any complications. But it's something unique to the patient's immune system and the inflammatory reaction that somehow this is a driver to increase their risk for developing stomach cancer. And it's certainly that subset, they may tend to do better, they may be a better candidates for immunotherapy drugs. But again, with these small subsets, it's going to, at least in the U.S., it's going to be hard to do studies. The TOGA trial, which got trastuzumab approved, was a global trial. Finding, and that was 20 to 30% of stomach cancer. So these very small subset trials are going to have to be done in high incidence areas. We can certainly participate in those studies, but we're probably not going to be able to have enough patients to really answer those kind of questions.
Just one more clarification. So if you took 100 patients with stomach cancer, you would find that 5 to 10% maybe had a history of having mononucleosis.
No, that's not. Probably everybody had mononucleosis. It's just that you find it in the cancer itself, and
at the time of the biopsy of the cancer. Okay. Thank you.
I have one last question for Dr. Ukar. I think this is a question about familial testing. Our older son was diagnosed with adenocarcinoma of the stomach at 17. When should we insist our younger son get genetic testing and start having labs done?
Where there's a hereditary syndrome of diffuse gastric cancer. It's the minority of the gastric cancers. But the median age that the patients are affected is around 38 years old. So the typical recommendation is for patients with this diagnosis that are found to have the CD1 mutation to undergo a total gastrectomy between the ages of 20 to 30. Now, if this family member had the diagnosis of diffuse gastric cancer at 17, I think the recommendation for the relatives of this patient is 5 years prior to the diagnosis of the youngest person in the family to undergo the total gastrectomy, because the incidence of gastric cancer in the lifetime is about close to 80%. So I would say for any testing, now is the time. I wouldn't wait to do any testing.
I think just to focus more specifically on the question, you would test the patient to see if they have a genetic syndrome. So, so a 17-year-old, it probably isn't going to be CDH1. It's probably just going to be, unfortunately, just a random event. I mean, the CDH1 mutation gastric cancer usually see in their 20s and 30s. So you test the patient. You test the affected patient. If there's no gene in that patient, then there's no reason to test the other family members. Screening you can do, but you know, and there's 5-year rule starting 5 to 10 years before the first family member is diagnosed. I mean, most stomach cancers don't run in the family. So, and there aren't clear guidelines for gastric cancer screening for first-degree relatives. We usually do recommend that they get screened, but this sounds like it's just an unfortunate event. And if the individual patient does not have a mutation or a syndrome that can be identified from genetic testing, there's no reason to test other family members. You're not going to find anything.
Okay. Thank you very much. Well, this concludes the morning. Thank you very much for this presentation. We're going to have our doctors who presented this morning around during lunchtime, so if you have any questions for any of them, please feel free. Yeah, we're going to get a little picture. Yeah. And then just wanted, before we break for lunch, I want to thank you very much for our, let's see if I can get this. Oops, sorry about that. So we're going to break for lunch now, and I'd like to thank our platinum sponsor, Lilly Oncology. And remember, at 12:30, please, if we'd like to do a survivor photo, so please come up here close to the stage. The food is set up already. Please grab some for lunch, and looking forward to seeing you. Please remember to visit on the side here, the booths, and if you'd like to purchase any like T-shirts or sweatshirts or jewelry, please look and see in the back of the room, and you can do that as well. Also, if you're interested in attending our gala tonight, please come see Mary Margaret in the back of the room. Thank you so much for a great morning session, and we'll be around for answering questions. Thank you.